Thank you very much, Christian, Professor Villacorta. Thank you very much for the kind introduction. Dear colleagues and friends, it is wonderful to be here in the wonderful Florence. And before I start, I just have to take the time and say that the quality of the presentations this year was incredible, and not only from the junior scientists, but also and especially from the senior scientists. So I'm really honored to even be mentioned in the same category as them. My talk today is going to be about syncope, unmet needs, and future directions. And if you're wondering what this young fellow is doing on the first slide here, I will come back to him later, and you will understand. So syncope management, why is it difficult and why is it important? Well, for one, syncope is very frequent and accounts for 1 to 2% of all emergency department visits, and around 30% of all people will experience a syncopal event at least once in their lifetime. Furthermore, syncope patients often have a very heterogeneous presentation to the ED, and also if they're suffering from true syncope, they often might not even have memory of the incident, which makes it even harder. But you also can't just put them aside and say, well, they had syncope, they feel fine now, so why do we even bother? Because you might actually be missing a life-threatening cause of syncope, such as cardiac syncope. And as management of these patients is actually really difficult. Unfortunately, we often see residents on the ED like this, which is quite unfortunate, and we should really try to do something about that. Whenever something is difficult and we don't know really what to do, we turn to the guidelines. And we also have guidelines for syncope. So we have the 2018 European guidelines for syncope, and we have the 2017 American guidelines for the evaluation and management of patients with syncope. And we recently published a paper where we retrospectively applied the risk stratification criteria and the admission criteria of both guidelines to the Basel IX cohort. And our findings were actually interesting because we found that the disagreement between the two guidelines was actually quite large. They disagreed regarding the admission decision in around 25% of patients, and also the sensitivity and specificity of both guidelines for the diagnosis of cardiac syncope and also for the prognostication for adverse events was actually quite low. So there's definitely room for improvement with the guidelines. And just to show you one graph out of this paper, you can see that regarding cardiac syncope, both the American and the European guidelines, so in green you see the discharged patients and in red the admitted patients, you can see that both discharged around 6%, so 150 patients who turned out to have had cardiac syncope. Compared to that, the actual physician decision was better in that regard, and they only sent home around 2.6% of patients who turned out to have cardiac syncope, but at the same time at the cost of a overall very high admission rate. So when we have a patient with syncope, what are our pillars of evaluation? So one pillar for sure is the ECG. And we looked at that, we analyzed the ECG criteria from the presenting ECG, and we identified a couple of factors that were predictive for an early diagnosis of cardiac syncope. There's symptoms. This paper is still work in progress. Some of you might already have read a first draft, but we were able to identify there criteria such as syncope while exercising, who were predictive for cardiac syncope. And also, just because we talked about this in the previous talks, we also found that women present with more various symptoms, with less specific symptoms when they had syncope. There's biomarkers, and we specifically looked at troponin and NT-proBNP and found that they were helpful in some patients, but overall had moderate performance. And then I also put physician judgment. This is kind of cheating because it integrates a lot of the other points, but I think it's still a very important part of patient evaluation. That's why I put it here. And we looked at that as well, and we found that actually the physician judgment had a very good discriminative performance for cardiac syncope versus other causes. And when you try to integrate all these different pillars or evaluation strategies into one, what you usually get are scores. And we have looked at scores previously, a couple of years ago, and we found that the performance of these scores were moderate at best. So in the guidelines, we have not any scores recommended, and we found the same thing, the performance just wasn't there. But since then, a couple of new scores were derived. So one of them was developed by a friend of the great consortium, Benjamin Sun, and they developed the FAIN score, which is a very easy to use score, consists of only a few variables, has very easy scoring, but already in the derivation, this score had only moderate performance, and we looked at it quickly and also found only moderate performance in our cohort. But then along came the Canadian Syncope Risk Score, and some of you might have already heard about this. This score is interesting because it had a very good performance in the derivation cohort with an area under the curve for 30-day adverse events of almost 0.9, and also in the national validation cohort, its performance was very good. The score consists of different items from clinical evaluation and investigation, such as biomarkers and the ECG, things we mentioned earlier, but also, and most importantly, it includes physician judgment. So it includes the discharge diagnosis from the ED. And that's vasovagal syncope, cardiac syncope, or another cause. And I think studies have shown that scores that include the physician judgment just generally perform better. And what we found when we validated this score, and we recently published this in Annals of Internal Medicine, was, you can see there's a solid line here, the performance of the CSRS of the Canadian Syncope Risk Score was really good in our cohort as well, with an AUC of 0.85. But most interestingly, when you look at the dashed line, here it's denotified as sync class or syncope classification, which is another word for the discharge diagnosis. This was, or had a almost similar performance with an area under the curve of 0.83. So it was almost as good as the whole score. So the question that comes to mind is, why is physician judgment good, but at the same time isn't? So we have the graph on the right where we can see that it has good discrimination. So apparently our physicians, when they discharge patients, have a very good feeling, or when they finish the evaluation of the patient, have a very good feeling about whether the patient is at risk or not. But at the same time, when we look at the graph on the left, we can see that they hospitalize almost 50% of those patients. So how do these two aspects fit together? And I don't know the answer, but I think there's some hypotheses. I called them soft and hard factors. So soft factors, for example, I felt were like when patients were frail or elderly patients presented in the middle of the night. Perhaps you're not going to send them home even though you're pretty sure it's not a high-risk syncope. And also hard factors, if a patient who you're almost certain that he had orthostatic syncope, but he got a concussion because he fell, then you're not going to send him home either. So it's, that might impact these data. And to be honest, our study and also every other syncope study hasn't really paid attribute to these factors. And then I found another study, or a survey that was published 2 years ago, and I found it very interesting because 55% of physicians, well, European physicians working in European hospitals, were asked how many patients they hospitalized, and they said over 50% said they hospitalized less than 25% of patients. And we saw that the real number is probably closer to 50. So it's a survey, it's not hard data, so it's probably, this answer is more like wishful thinking, and we all may or may not know this from other areas in life. 88% of the physicians said they do not have syncope units, and this didn't, I wasn't wondering much about this because I think in Europe at least syncope units aren't that big of a thing yet. But what was impressive to me was that 55% of physicians said they do not have syncope-specific protocols. And I think that this is actually an issue, because if you have a disease or a presenting symptom, whatever you want to call it, that is very difficult to manage, and then you have all the doctors that care for the patients and they do not have a specific protocol how to deal with them, I think this can only lead in failure. So as an example, and I'm not claiming that it is perfect, although Christian might disagree with me, this is our syncope evaluation strategy for syncope patients in Basel. We have a platform called MedStandards where we have different guidelines for different, mainly ED patients. And you can just, if a patient with syncope comes to ED, you can follow these different steps to evaluate them, and you get some help on the way. Now we talked so much about problems with syncope, so while I was doing research for my presentation, I came across this quote, and it was here attributed to John Lennon, who was on the first slide already, and it said, "There are no problems, but only solutions." And I was wondering, because the whole topic of this talk is basically about problems with syncope, so I did some research, and I was thankfully able to find that John Lennon actually never published anything regarding syncope, so I think we're safe to ignore this statement here. So how do we proceed from here? This is not really a conclusion, but more of open questions that I would like to present to you. Do we perhaps need new scores that help us in the evaluation of patients with syncope? We have some scores, they performed well, maybe the Canadian syncope risk score. I'm happy to hear what you think about it. Do we need new biomarkers? We have evaluated some. There are some new biomarkers on the market that were not widely evaluated yet, so perhaps that is a solution. Should we just trust the physician judgment? Is there even a problem? Because we saw that theoretically the physician can discriminate just fine. Do they even need more help, or should we just trust what they decide? Or perhaps do we really need syncope wards? Do we need specific protocols for the evaluation with syncope? Again, unfortunately, I don't have the answer to these questions, but I'm happy to discuss this topic, and I'm happy to answer any question if I can. And with this, I would like to thank every one of you, and thank you for having me.
Thank you, Tobias, for another great senior scientist lecture. Are there questions from the audience? Yes, I see one over there.
You can't ask about type 2 this time.
Sorry, we can't hear you that well.
Is that better?
Yeah.
Yes.
Yeah, a lot of the focus locally has been on wearable devices and patches. And so our syncope protocol has rapidly moved to just sending them home, irrespective of the risk, with a patch on. And we're doing observational and randomized studies there. I'm interested in whether that, I couldn't read your protocol, sadly. Jasper is working on my Swiss, but I couldn't quite read it. Do you use patches? What's your approach to follow up for rhythm disturbance?
So that's a very good question. Thank you very much, Nick. I think this is difficult. We do not use patches or anything like that yet. I think if you use patches and outpatient management in patients where you're unsure if it's cardiac syncope, you have to be very careful, because it's the same if you use Holter monitoring in the hospital, but they're not live monitored, it's just being recorded. So you have someone who are not sure if they have cardiac syncope, you send them on the ward with a device, they arrest, they die, and afterwards you know, well, it was arrhythmia, great, it was cardiac syncope. So that doesn't help very much. So I think if you use patches and devices for outpatient management, which would theoretically be great, I think you have to have the right infrastructure to have a live monitoring of some degree, and some alarm systems that go off if the patient has arrhythmia. I think those are very important factors to consider, and I don't know how exactly this system works in other countries, but I think it's probably not very easy to really do this well.
More questions from the audience? Yes?
My question is, if you have a patient with syncope coming to ED and you're monitoring him from the beginning for, let's say, 4 to 6 hours, that he is in the meanwhile, that he is in the ED, like we do in many hospitals in Italy. This adds something, the judgment of having is included in the guidelines.
That is also a very good point, thank you. It's one of the reasons, is what you said, that we excluded patients with an event on the emergency department for the evaluation, for example, of the Canadian syncope risk score. Because the idea of the Canadian syncope risk score, at least, was not an early triage when the patients come to the ED, but have a disposition decision aid for the physicians when they leave the ED, basically, should they be discharged or hospitalized. And when we excluded those patients with an event on the ED, I think it was around 10% of patients who had an event while being monitored on the ED, but the rest of the arrhythmias or whatever events just occurred later. So it definitely has an impact, but those patients were excluded for this study.
Okay, I have a question too. You mentioned some difficulties in the evaluation of older adults. Do you have any information on pre-syncope or almost fainting or near syncope?
So we did not include patients with pre-syncope in our study in Basel, but we due to the kindness of Professor Sun and in collaboration agreement, we had access to the data of the SRS study, which is a large multi-center US study in patients with pre-syncope and syncope. And I cannot give you any exact numbers because it's quite some time ago that we looked at it. But actually patients with pre-syncope, the outcome of them wasn't that much better compared to patients with real syncope, so it was quite similar.
Okay. Last question from the audience? No? Okay. Thank you very much.